Welcome to Fuqua's LinkedIn Live question and answer session. I'm Peter Ubel, faculty at Fuqua. I thank my wonderful colleagues at Fuqua for helping arrange this session. I'm going to talk for a few minutes and then take your questions, and helping me field those questions will be a current Fuqua student, John Nye. John, please introduce yourself to people.
Thanks, Peter. Thanks for having me. My name is John Nye. I'm a second-year student at Fuqua, originally from Minnesota. My background's in consulting and internal strategy, and I came to Fuqua specifically to transition into the healthcare industry. So I was part of the HSM certificate program here.
Thanks, John. And you can leave questions for me in the comments section of this post, and John will be helping curate those and try to get in as many of those questions as you can. But first, I'm going to just talk about a couple topics, and your questions can relate certainly to clarifying or further exploring the topics I discussed. But if other things you think are worth discussing, I'm happy to do so. But I'll let you know, there's only so much I know. We're in uncertain times. And it's really stressful. We don't know how bad this virus is going to be. We don't know the best way to treat it or prevent it. And we don't know how to balance protecting the public health and the economy, which is also really relevant and related to people's health and well-being. So these are really, really difficult times. And I think there's a natural inclination for us to all want to help out in those times. And it certainly gives me the temptation to start spouting off about things I don't know much about. I'm going to try to resist that temptation today. I am trained as a physician, a primary care doctor. I've been studying how people make decisions about health and healthcare for about 30 years now. So that is my expertise. How do people make decisions? And I'm going to try to take a couple lessons from that expertise and bring it to bear on the COVID pandemic. And I'm going to talk about two things. One, I'm going to talk about out-of-pocket medical costs, and the second, I'm going to talk about immunity tests and immunity passports. And then, like I said, happy to take a broader set of questions from you. So first, I'm going to just briefly talk about out-of-pocket medical costs and how those relate to the COVID pandemic. Some of you might know that in the United States, a very large bill was passed called the CARES Act, did a lot of things, trying to give out a lot of money, trying to save people in lots of different ways. But one of the things that bill did, that law did, is it has eliminated any out-of-pocket costs for COVID-related tests and treatments. And when I talk about out-of-pocket costs, I'm not talking about the monthly premiums people pay for their insurance. I'm talking about the deductibles, the co-pays, the co-insurance, the extra things, the fees they have to pay when they receive medical care. The CARES Act, I think very wisely, didn't want money to get in the way of people getting necessary tests to see if they're infected with the COVID virus, and they didn't want it to impede people's ability to get medical care to treat them for COVID-related problems. The problem, as I see it, is that it didn't go far enough. I have a book came out this fall called Sick to Debt, not death, Sick to Debt. It's all about how in the United States we've been pushing further and further to expose people to the out-of-pocket costs of their medical care. The idea being that will force them to savvily scrutinize the cost and quality of care and decide whether they really need that MRI for that little shoulder pain they got last weekend on the tennis court, or whether they can hold off for a few weeks before getting that test. What we know from a lot of studying of how people make medical decisions is that when they face steep out-of-pocket costs, they get less medical care than if that care is free. People think twice about going to a medical appointment that's going to cost them a lot of money. And that's why people think this is a good way potentially to get people to be a little bit more cautious about how much medical care they consume. One problem with that, however, is most of us don't know when we need to see medical care urgently or not. That heartburn you have, is that a heart attack or just a little bit of acid reflux? That shortness of breath, is it just a little bit of reaction to some pollen, or do you have a COVID infection? We know that when people face high out-of-pocket costs, they get less medical care, and they're just as likely to skip necessary medical care as unnecessary medical care. And my take on it is, in the face of this pandemic, this is not a time people should be thinking about any out-of-pocket medical costs, because you might come in right now with shortness of breath, and it turns out it's because you had a heart attack and you're not pushing blood through your lungs very effectively. Should you get charged out of pocket because you had the wrong illness, that you didn't have a COVID-related disease, so you get to pay a lot out of pocket? And what happens if word gets around the neighborhood that so-and-so went to the hospital thinking he'd get free care because it was a COVID infection, found out it was something else, and now he's got thousands of dollars in medical bills? Will that keep the next person from going to the hospital when we want them to? So I think right now it'd be good to have a hiatus on any out-of-pocket medical costs in the United States, 2-3 months worth. People aren't getting routine medical care now anyway. I don't want people thinking twice about whether to go seek medical care because they're worried about the costs. Now to shift to a very different topic, but again, it has to do with decision making. In the first one, I talked about people's decisions whether to get medical care or not. In the second, I'm going to talk about the decision about whether to re-enter the world feeling you're safe from further infection. And that would be if you happened to be exposed to the virus already and your body had built up antibodies to the virus. And so just to be clear, there are at least two kinds of tests for COVID. One is the one where they're sticking the swab basically almost into your brain and finding out, do you have virus right now in your body? Are you currently infected? But there's a second type of test that's just starting to come out now. Some people call it immunity tests or serology tests. It says, have you been infected with the virus, and does your body have antibodies now to fight future infection? Some people even talked about, if we get good tests, then people can use them to decide whether they can head back into the economy and take a job and not worry about social distancing, not worry about contracting an infection, and therefore not worry about spreading the infection to anyone else. And I'm going to just give a little sense of how, as we make decisions about when we're safe to re-enter the world and not worry about a further infection, is that we can be misled because it's really hard to understand what it means for a test to be accurate enough to guide those kinds of decisions. And I'm going to run a little math by you. I apologize in advance. And maybe some of the Q&As I can clarify what I didn't explain well. But let's try this. Right now, there have been a lot of tests that have been approved by the FDA, but some are not so great and some look really good. And I'll give you one example of a test. Came out, you have it run 1,000 tests on people that we know have not been exposed to the virus, and only 40 times does it come out and mistakenly say, oh, they had the virus. So that sounds like a really accurate test. The problem, though, is how much you can trust the result of a test depends not just on how good the test is, but on how common the disease is in a population. So imagine we go to an island, a remote island, where the virus has never appeared. We test 1,000 people. 40 of those 1,000 get this immune test positive. We know that all 40 of those would be wrong. So every single positive test would be a false positive test because the disease is so rare in that population. So you don't just need an accurate test, you need to know what's going on in the population. Our best estimate now is probably 4% of Americans have been exposed. That means if you test 1,000 Americans, random Americans for the virus, 40 times the test will correctly say, ooh, you had the virus. But another 40 times it's going to make that mistake and say, you had the virus when you didn't. That means you have 80 people who think they're immune and only half of them are correct. And we don't know which half. So it's a real challenge to know, as people are pushing to have home antibody testing, whether people are going to misinterpret the results of their own tests. And because it's really hard to make sense of some of this information and avoid. And to just give you a sense of how a test like that might be used more effectively, if you gave that test to a bunch of people who've been taking care of patients in an intensive care unit that's been ravaged by the COVID virus, almost every time that test came back showing antibodies, it would probably be correct because a lot of those people have been exposed. Run that test in Montana, where almost no one has been infected, and you can bet that that test more often than not is wrong. And so we have to not just look at the test result, but we have to look at the context of what's been going on to better interpret that. So we have to be, I think, really cautious in thinking about how to move forward. It's going to be very challenging to open up the economy without risking people's health. And currently, I think this idea of an immunity passport is probably not ready for prime time, because I don't think any test could be accurate enough to give us anything but a false sense of security. So yeah, John, I'm curious if that made any sense, and if you have any questions to run by me, or if any questions have come your way yet.
Absolutely. I mean, I have some follow-up questions on the immunity passport
Yeah.
in particular. I was watching the news this morning and they were talking about these home test kits that can cost $200, $250, and they aren't approved by the FDA necessarily. I guess my question would be, what would the role of the FDA be in this sort of immunity passport, given how fast, the desire is to reopen the economy and how quick any of these actions might be? Should all testing be approved by the FDA? And if not, what would you recommend?
Yeah, thanks, John. That's a great question. So I want to put the passport idea aside for a second, because that's going to be some kind of policy about who can officially work in what kind of jobs. And let's just talk about instead, what kind of tests should be out there and who should be able to use them and how can we help them interpret those? I think it's a mistake. First off, I think it's a mistake to lower your standard for testing. If you're the FDA right now, I think you should still maintain rigorous criteria for when a test is good enough to be FDA approved. We're feeling the urgency of this epidemic and we're trying to move faster than normal, but we shouldn't lower the standards for that kind of testing because it can be so misleading and then have the bad consequence of making people feel safer than they really are and therefore worsening the epidemic. That might be a different thing that the FDA has to think about when there's a medication to treat the infection, where they might be willing to get a medicine out to market a little earlier than possible because the devastation of the people who are hospitalized with the virus, and you're willing to put up with a few more side effects to see if it helps. So I'd say we should have very strict criteria for those immune antibody tests. At the same time, we might relax some of the safety criteria for medications.
Thanks. We have a few questions from the LinkedIn audience. I'll ask two of them together. They're related to healthcare costs. So one is just, do you think that healthcare costs are going to go up because of COVID? And then related to that, do you think that health insurance premiums will increase because of COVID-19?
Wow, those are, great questions. It's hard to predict, obviously, so I'm not gonna, this is where, you don't want to step outside of your expertise. But right now, what I've heard is that overall healthcare spending has declined dramatically in the last month. And if that were to continue for a few more months this year, and if there wasn't some big rebound later in the year, insurance companies might end up with have a pretty good year because so many people have put off discretionary or services. They've delayed maybe what you might even think of as necessary but not urgent care. And so overall healthcare spending might actually be declining this year. Now, that could very quickly change. If we start opening things back up, there might be pent-up demand, and then you might see a big rush of people getting procedures done. I don't think they're going to be able to catch up with how many procedures they would have been doing at this point, though. So my best guess is we're going to see lower healthcare spending this year than last. Now, what about next year's premiums? Next year's premiums aren't just based on this year's expenses. They're based on what the insurance companies think people will spend next year. And so they're going to be in a huge guessing game of how much of that pent-up demand will now start coming to bear next year, and people start getting all those hip replacements they delayed, and will they end up with a more expensive than average year? There's nothing insurance companies dislike much more than uncertainty, and they're going to face a lot of it.
I think that makes a lot of sense. Actually, that brings up one question I would have about, we have millions of people who are now unemployed, and for those Americans, that means they have a loss of healthcare in many situations. For many of those Americans, and if they're hourly employees who maybe don't have access to healthcare through their employer, do you see a kind of a movement towards the government exchanges being almost necessary at this point, or is there something else that you think might be done legislatively to address those individuals?
Gosh, great question. This crisis has certainly pointed out the dangers of having a health insurance system that depends upon employment, and that's linked so often to employment. So people who are 65 or older haven't lost their insurance during this pandemic because most of them are on Medicare, and that coverage has continued. But people who lost their job and can't afford to pay the insurance, even after you leave a job, you can continue to keep on that insurance plan for a while. It's called Cobra, but you have to pay even more per month than you used to because you're covering your part and what the company would have covered. And if you just lost your job and are unemployed, that's not affordable for a lot of people. And so I do think we're going to have to, as a country, think about whether it makes sense to tie insurance to employment and think or consider whether there's a better alternative. Whether that happens or not, really hard to predict. A lot will depend on the outcome of the next election.
Thanks for that insight. We have a question here from Murali Krishnamurthy, MD and MBA. And she asks, auto insurance is giving some refunds. Do you anticipate health insurance giving refunds to individuals?
Wow, that's a great question. I'm happy to say I don't know. There are some regulations that might actually make that happen. In a part of the Affordable Care Act, it said that insurance companies, if they were to take in, for every $100 of premiums they take in, they need to spend out at least $85 in medical care so that we know they're not just withholding necessary care from people in order to pay out the bottom line. So that's called a medical loss ratio. So if it turns out that we continue to underspend in medical care for the next few months, insurance companies might need to give some premium discounts just so that they don't violate that part of the law. And so that might be a nice benefit for people if you still have insurance.
Absolutely. We have another question from an alum, Shomita Mandal. What has been the barrier or have been the barriers to fully utilizing the DX tests developed abroad?
Use what tests? I'm sorry.
It says DX tests.
Oh, diagnostic tests.
Yes.
From abroad. I don't fully know. I think it's really important that we recognize we're in this together, the entire world. We can even get caught up in whether it's a blue state or a red state that has more infections or is doing the right things. That's really toxic and really sad. But we should also remember this is a global pandemic. And the best way to fight that kind of pandemic is to do it together. Because even if one country did a great job of shutting things down and getting the virus under control, somebody from another country could come in and start spreading it again. We all need to work together. And that probably means, sharing technologies like better tests, better treatments.
Great. We have another question here from Jennifer James, an MBA. Professor Ubel, what do you think will happen to the progress of consumerism and price transparency in healthcare?
Yeah, so that's a topic I think about a lot. It's one of the main topics from my book, Sick to Dead. One of the crazy things that's happened in the last couple of decades in the United States is we've exposed people to more and more out-of-pocket costs for their medical care. And that can be if you're on Medicare and you're exposed to 20% of certain costs. It can be if you get insurance through your employer and your employer only gives you a choice of high deductible plans. This has become about a quarter of employers only offer high deductible plans to their employees. Another quarter are thinking of going in that direction. So people are facing higher and higher out-of-pocket costs, all out of this theory that will make them scrutinize the cost and quality of their care. At the same time that happened, almost nothing was done to help people actually find out the price of care in time to inform their decisions. It's like you can't shop savvily for medical care when you can't find out what it costs, and it's kind of hard to figure out how good it is and how necessary it is. And so I think it feels like a very bipartisan issue that whether you're liberal or conservative, you shouldn't want people shopping in the dark for medical care. And unless you're in some world where there are no out-of-pocket costs, which I don't anticipate and I don't even endorse, I think we need to actually have legislation, at least at the state level, that just mandates prices become transparent. The state of New Hampshire is about the only one in this country right now doing that well. They have a website you can go on and figure out what everything costs just by clicking on one website. That should be happening across the country.
Well, thank you. We have another question here from Jan Cooper. Germany has fewer deaths compared to other countries. Is this directly related to the German healthcare system?
Well, so my name is Ubel. It's German for either nauseated or evil. I think it doesn't say much about my ancestry in either case. That's very good. but I do like to think of myself as Dr. Ubel. Yeah, it's really complex to know how much has to do with the health system or not, because you can point to countries that have universal coverage through government payers and have high rates of infection or low rates of infection, high rates of death, low rates of death. You can find the same for private systems. And there, so much has to do with broader cultural things, with how well functioning a specific federal government is in this moment in time. And then random things, whether somebody happened to come to a pharmaceutical conference who had no symptoms and blew virus around a room and started infecting a bunch of people who traveled back around the country. So it can be kind of random too. But I'll say this, Germany is a model potentially for how the United States could improve its own healthcare system without turning to Medicare for all or some kind of socialized payment system. Germany is almost exclusively private insurance companies, but it's mandated that people get that insurance coverage. And the insurance companies are heavily regulated so that they have to provide substantial and similar benefits across plans. And that has given people a sense of security in their healthcare coverage that is an envy. We here in the United States kind of envy. We are certainly as wealthy as Germany, and people should be just as likely to get healthcare coverage here as they are in Germany. You don't have to turn to a socialized system to accomplish that.
Thank you for that answer. We have another question from Rebecca Cook in North Carolina. What kind of spending will hospitals and other organizations, universities, corporations, be investing in to pivot after COVID for prevention? So things like temperature check and body scans at building entries, and continued social distancing, working and learning tools, teleconferencing, and then also telemedicine as well. So pretty broad question, but I guess kind of what do you see as the future of investment in the post-COVID world?
Yeah, I mean, I think all those things we're going to have to invest in them. And I'd like to think we're doing it as part of a coordinated plan, that at least guidelines are being set, maybe coordinated federally. And there probably needs to be funding, because a lot of, not just healthcare places, but a lot of workplaces are going to have to do more temperature checking. And I don't know, even that's only so effective because a lot of people don't have fever who have the COVID infection. A lot of people don't even have symptoms and they're infectious. So maybe there are workplaces that are going to have very frequent testing to see if people are safe to come back to work or not. Someone has to pay for that. We have to figure out how to do that. And so I do think we're going to need federal legislation to help make that happen. Then I think we have another issue, like thinking of healthcare system more generally. When this is behind us, which I know we all wish was yesterday, we have to be prepared for the next pandemic, because there will be a next pandemic. There will be many next pandemics. And partly what we have to recognize is that what we learn about a business school about how to run efficiently, time on demand delivery and production of goods and services makes a ton of sense until you need twice as much stuff as you thought you needed and you're in the middle of a pandemic. And that partly what a system has to do, and this is again going to have to come as a social goal that probably needs government support, is to invest in resources that we hope to never use. That looks inefficient from the strict standpoint of how a business runs, but is incredibly important to do to prepare for this kind of pandemic.
Absolutely, you have to always prepare for the unexpected. Kind of leads into one more question here that we have, which is more about what we can expect after this in terms of changes to healthcare. Is there what downstream effects do you think we will see post-COVID? And would this include increased obesity or mental illness that you expect from the social isolation that we've kind of been living in the last few weeks?
Yeah. So I do, that's a really powerful question. I do think the mental toll is going to be prolonged and difficult, and probably physical toll too. In North Carolina, we've had the advantage of being cooped up during a beautiful time of the year. And it is pretty safe to go outside in places that aren't super populated. North Carolina is not a heavily populated state. So you can go out and walk on a trail and not run into many other people, and you're getting out and moving, and that's great. I have relatives stuck in northern states where it's hard to get outside and it's really cold. And for elderly people in particular, it's unsafe because it had been icy until a couple weeks ago. So we're going to have that kind of toll. Another toll that's going to happen is we've had a lot of people who have recovered from this illness, but there's recovery and then there's full-on recovery. For those who've had really serious symptoms, maybe they ended up in intensive care for a while, or maybe they were short of intensive care but got really sick, there can be lingering effects from that. We know from studies of people with other types of pneumonia that it is months before people feel back to normal. And in fact, making sure people understand that's important, because there will be people where it's 2 months after they've been out of the hospital and they just feel terrible. They barely get going in the morning and they start thinking, why am I so depressed? Which makes them feel depressed, which makes it harder to get up in the morning, and it's a vicious cycle. We have to remind people, no, it takes months for your body to recover from this kind of an illness. It is normal to feel off for quite a while, and you just to continue to need to get help to deal with those symptoms, and you also need to be patient and know it's going to take time to recover.
Absolutely. I know I've been trying to get outside every day as much as I can just to keep sane here. I see we're at the 5-minute mark and we have a bunch of questions here, so I want to get through a few more.
I'll be really quick. Okay.
We have another one from an alum, Doug Dickerson. Do you think that the rating companies such as Moody's will change their ratings of hospitals? And if so, how? And I think I'd like to further break that question out into the rural and the urban hospitals and get your take on kind of what the future of those environments might be like.
Yeah, I can tell you know nothing about Moody's and those kinds of aspects of it. I will be happy to plead ignorance to that. Hospitals have lost a lot of lucrative revenue in the last couple months. Procedures that tend to pay, I think, more than they should, but that have the lifeblood of the finances for hospitals. And then they've sometimes sat and waited for a bunch of patients to come in that didn't, or when they were in an area where a lot of people got sick, it doesn't pay well to take care of people with pneumonia. It's just not as lucrative as replacing people's hips or putting pacemakers in and things like that. So a lot of hospital systems are going to be in financial difficulty, and rural hospitals in America were already in substantial financial difficulty. And by the way, even more so in states that did not expand Medicaid, where you have low-income rural populations that haven't been able to pay for medical care. So there's going to be a fallout, and it's going to be where it leads. I'm not sure if that's more consolidation. If there's a recognition we need to do more to help these kinds of hospitals, I don't know.
And then we have, I think, time for one more question here. So I'm going to end on a positive note.
Yeah, I'll try.
What do you think will be the new healthcare management career opportunities that might come out of this pandemic?
Well, first, I'll just say that healthcare is a great place to work, period. There's a ton of innovation, there's a ton of opportunities, and it's meaningful work. You're sometimes saving people's lives or dramatically improving the quality of their lives. And I think it's really rewarding. It's a joy to teach at Fuqua, because I get so many students who have this mixture of idealism and ambition and want to do innovative, challenging careers in an exciting field. And I think healthcare is that. And I think, how can it be less that way after this pandemic? People recognize the importance of a strong healthcare industry more than ever. Hard to imagine the laboratory testing industry not being changed by this. Not hard to imagine people not appreciating their local hospitals more than they did beforehand. So I do think, and even if drug companies that come up with really effective treatments, hallelujah, that's gonna be really good for their business and for probably how people perceive their industry.
Great. Well, thank you so much, Professor Ubel. And I was wondering if you could take some time to tell us about the other LinkedIn Live events that Fuqua will be hosting in the coming weeks.
Yeah, and I want to thank Fuqua for pulling this event together. I want to thank all of you for excellent set of questions. And maybe we'll put up a link. You can email me if you have other questions. I can try to answer them the best I can. There will be another session every Friday or Wednesday at 12:30 Eastern time. Fuqua will continue to hold these LinkedIn Live sessions. Follow Fuqua on LinkedIn, and you'll be alerted to these and other events. And next week, Gavin Fitzsimmons is going to be talking. He's a marketing professor. He'll have some really interesting insights about kind of the behavioral responses to what's been going on now. So that should be a great event.
Oh, I took his class as well. I took a class with Dr. Ubel, and I can tell you that they are both wonderful. So definitely tune into those. I think you'll enjoy it quite a bit. Great. Well, thank you so much, and enjoy the rest of the day outside in North Carolina.
And everybody stay healthy, and thank you.
Absolutely.